Welcome to this webinar on patient-centered opioid deprescribing in low-resource care settings. And this will be hosted by Dr. Aram Mardian and myself. I'm Dr. Beth Darnell.
Hello, my name is Aram Mardian. I'm a family physician and clinical associate professor of family, community, and preventive medicine at the University of Arizona College of Medicine, Phoenix. Also have additional certifications in addiction medicine, pain medicine, and medical acupuncture, and work as the chief of the Chronic Pain Wellness Center at the Phoenix VA.
Great, thank you, Aram.
So I have no disclosures or conflicts other than the fact that I am the site director, site PI for the Empower clinical trial, which is a trial looking at treating chronic pain and opioid reduction, and it's funded by PCORI.
And I'm Dr. Beth Darnell. I'm an associate professor at Stanford University School of Medicine in the Department of Anesthesiology, Perioperative, and Pain Medicine. Just at a high level, I'm a principal investigator for NIH and PCORI-funded studies that broadly investigate behavioral medicine strategies for acute and chronic pain management, as well as patient-centered prescription opioid reduction. I've authored several books on the topic, and these are my disclosures, funding disclosures from PCORI, the patient-centered opioid reduction, as well as from NIH. I'm also a chief scientific advisor for Applied VR. These are books that I have authored or co-authored, and I disclose that I am the creator of Empowered Relief, which is a single session behavioral medicine class that will be discussed later in this webinar. So the learning objectives for our time together, we are going to discuss information that will equip you to apply strategies to determine which patients on opioid analgesic therapy might benefit from deprescribing. You'll be able to describe key behavioral strategies to help move your patients along the pathway from resistance to readiness to engage with a tapering trial. You'll be able to list potential harms and benefits that are associated with opioid tapering and the individual factors that can predispose a person to each. And finally, you'll be equipped to list 3 strategies to enhance patient safety and comfort during opioid reduction. So our outline for our time together, we're going to be discussing a lot of background on the topic, moving into a risk-benefit assessment plan and protocol. We'll be discussing who's right for opioid tapering. Then we'll go into the nuts and bolts of patient-centered opioid tapering, the actual implementation. And then finally, we'll review a whole host of resources that are provided to you as an attachment to this webinar. We'll be using clinical vignette strategies to illustrate the clinical concepts that we're discussing as we go forward through our time together to really bring the content to life. So the most recent report from the Institute of Medicine, published in 2011, put forward data to illustrate what a massive problem ongoing pain is in the United States, with up to 1 in 3 individuals living with ongoing pain of some type. And this is of tremendous economic consequence to the nation, but at the individual level, it confers suffering and erodes quality of life, both for the individual and for their family. And we see that opioids had been increasingly prescribed over about the last decade and a half or so. And we have seen that there has been a correlation between opioid prescribing and also opioid-related mortality. Although this slide here from the CDC really illustrating that a lot of this uptick, the sharp uptick that we've been seeing in the last few years involved synthetic opioids and heroin. So these really being some indication that illicit use of opioid-containing drugs is driving a substantial portion of these overdose deaths that we've been seeing. But nevertheless, this has spurred an intense focus on the issue. There have been calls to deprescribe opioids from multiple government agencies. And this call to deprescribe opioids to reduce opioid prescribing has been of tremendous consequence to a substantial fraction of the population. Data from 2017 suggesting that about 11 million individuals in the United States, close to 3.5% of the adult population, is taking daily opioids. So these calls to deprescribe are particularly impactful for this key patient population. And the Centers for Disease Control, the FDA, the Institute of Medicine have all called for deprescribing to help improve the health and safety of our patients who are living with chronic pain. But of course, you know, the million-dollar question is, how do we do this the right way to really and truly assure that we are improving safety, we're improving their pain, and ultimately that we're improving their functional outcomes and quality of life. So I want to introduce the case of Susan. So Susan is a relatively high functioning woman who was an architect working full time, but she has moderate depression, and this has been worsening lately. She has anxiety, she has insomnia. She has a history of chronic neck and low back pain, and she's been taking 150 morphine equivalent daily doses for the past 3 years. Now, Susan's kind of reticent to reduce her opioid medication. She feels that she's holding things together right now, and she's disinterested in any change. So, Aram, I'd like to hear from you how you would approach this individual.
Yeah, thank you, Beth. So this case, and maybe we'll kind of switch over to our next slide. We really are starting to look at major challenges for PCPs, and really not only for primary care providers, but for any healthcare professionals that are coming into contact and trying to help Susan. So we can think of, there's been really a tension created between these broad recommendations for deprescribing that you've talked about over the last several years, and yet our patient is resistant to those recommendations. Our patient is really not interested in participating in that type of treatment. So we have that tension, and yet with those broad recommendations, we really, unfortunately, haven't been trained or given kind of detailed approaches to how to resolve that tension. And then compounding on that tension is the fact that really primary care providers have received conflicting messages about how to manage a patient like this who has chronic pain and on long-term opioid therapy over the last 25 or 30 years. So in the last 30 years, PCPs have been taught to really take the same approach that they've used to treat acute pain, meaning looking for a pain generator, trying to numb or remove or eliminate that diseased body part, and applying that same approach to chronic pain. Now, that approach works very well when we're treating something like a broken bone or an abscess, but it doesn't work very well when we're looking at something like fibromyalgia or chronic low back pain. PCPs have also been given the message starting in the 90s and early 2000s to use opioids aggressively to eliminate pain because there really are only, they were told, minimal risks associated with opioids, and opioids are effective. And then more recently, in the last few years, PCPs have gotten the message either implicitly or explicitly to stop using opioids because they're harmful and ineffective. So our goal here today is to provide evidence-based recommendations for evaluation and management of patients like Susan, and unfortunately recognizing that there often isn't evidence to guide certain situations. So where evidence is lacking, really falling back on and relying on principles of safety, individualizing care with our patients, and collaborating with our patients.
Yeah, that was so beautifully stated, and I just love the emphasis on the safety aspect and always bringing into our awareness that that's really our highest goal, is to ensure the safety of our patients. So as you mentioned, Aram, I mean, it really remains that throughout the United States and really throughout the world in general, that pain is primarily treated as a biomedical symptom. And so we do maintain this reductive focus on what's happening physiologically. And we've known for decades that pain is best treated using a biopsychosocial approach. But we don't tend to implement that. And part of the reason why it's not implemented, this broader biopsychosocial treatment approach, is because we don't necessarily have the resources to implement it. So one of our goals with this webinar is to help give you some tools and structure so that you can better apply the biopsychosocial model within the context of opioid reduction for your patients. Now, this biopsychosocial treatment approach really makes sense when we reflect upon the actual definition of pain. And this is from the International Association for the Study of Pain, where pain is a noxious sensory and emotional experience. So this is not well appreciated, that psychology is built into the definition of pain. And so with this reductive focus on what is happening physiologically, we miss this half of the definition of pain that fundamentally involves the person and everything that is happening that could be serving to amplify their pain. Now, pain is highly complex, and it's influenced by a whole host of factors, including the context in which we experience the pain, the meaning that we attribute to it, the way that we're responding to our pain, our thoughts and our feelings, our mood, the attention that we give to our pain, and even various social factors. So just to illustrate some of the complexity of pain, I wanted to just briefly dive into this study because it does involve opioids, and it can broaden our thinking about how critical our patient's psychology is within the context of pain and opioid analgesia. So this was a study that was conducted by Irene Tracy and colleagues in the UK. And this was an experiment in which they brought healthy volunteers into the lab, a group of healthy volunteers. And every single person who came into the lab received two things in this experiment. They received heat pain testing on the palm of their hand. So we place a thermode on the palm of individuals' hands, and we can standardize the application of heat and elicit pain, even in pain-free individuals. So they got heat pain. And the other thing that they got was an IV placed where they were receiving remifentanil medication. So remifentanil being a powerful opioid medication. And all participants in this study got heat pain and remifentanil through an IV under 3 conditions. Condition 1, they were told they were receiving remifentanil. So you're going to receive this heat pain, but don't worry, you're getting this medication and you won't have any pain. Condition 2, they were told that they were receiving salt water solution in the IV. So they would receive the heat pain. You're not going to receive any pain medication. You're definitely going to experience pain, but you won't be harmed. Condition 3, they're told you're receiving the heat pain and we're going to be giving you a medication that's going to worsen your pain. So again, you will not be harmed, but we want to prepare you that you're going to have worse pain. Now, notice that across these 3 conditions, the only thing that the experimenters are manipulating is patients' expectations and beliefs about the medication. And this was fascinating. What the researchers found was that in condition 1, when patients were told and they believed that they were receiving an opioid medication, the analgesic benefit of the remifentanil was doubled relative to when patients were told that they were getting nothing. And when patients were told that not only were they not getting any opioid medication, but that their pain would worsen, the analgesic benefit of remifentanil was completely abolished. So this stands as an illustration of how powerful our expectations are, that they can literally alter the analgesic benefit of medication and can serve to amplify our pain. These data slides just show this potent effect of our expectations for treatment on pain intensity. And the researchers correlated this with neuroimaging to be able to show that indeed, based on a patient's expectations, pain processing in their central nervous system actually correlated with their increased reports of worse pain. So just pause for a moment and think about what's happening around the United States when patients are told that their opioid medications will be reduced, either for whatever reason, whether it's because there's a national call for deprescribing, or whether one's healthcare organization or even their clinic is asking them to reduce their medications. The patient's expectations and their fears around opioid medication reduction can stand in opposition to the opioid medication itself, so that their fear, their worry about opioid reduction can actually undermine their response to whatever opioid medication they are taking right at the critical time at which we're reducing their medications. So we're going to be weaving throughout our time together this focus on expectations. A negative expectation for pain is what we would call nocebo. It's a fear that one will be harmed or that one's condition will worsen. So nocebo for opioid tapering is quite formidable, and you may have observed yourself that this stands as a barrier to patient engagement in opioid tapering, and it also stands as a barrier to their response to opioid tapering. So turning it back to you, Aram, how do we treat Susan?
Yeah, thanks, Beth. So such a fascinating study. Really appreciate hearing about that, and look forward to hearing more about expectations and placebo, nocebo effects, how we weave those in. I also love how you talk about psychology being built into the very definition of pain. And now we're going to look at how we might start to build that into the assessment and evaluation and also the treatment. So when we think about how do we treat Susan from a biopsychosocial, a whole person perspective, we can start with thinking about transforming the way we evaluate her and her condition. So many of us were taught, and we can think about transforming from an evaluation of pain, which is focused on identifying disease in a specific body part, and really only focusing on pain intensity as an outcome, and shifting to evaluating the whole person with a focus on social, psychological, and physical factors. And instead of only focusing on pain intensity, looking at function and quality of life. And actually, sorry, just going back one slide there. So our patients often come in, and they might say something like, "Doc, I have pain in my L5 vertebrae," right? So they also have internalized this very biomedical approach to chronic pain. And so looking at our next slide, we're thinking about kind of our lens of focus and looking at a narrow versus a wider lens of focus, and recognizing that really this overly simplistic and outdated approach to pain is very deeply ingrained in ourselves as healthcare providers and also our patients. So we kind of get wrapped up in really focusing on a purely physical cause, and ignore the fact that, again, psychology is built into the definition. So a patient might come in and they have elbow pain, and with a narrow field of focus, we're really looking only at the elbow. And maybe we might look up to the shoulder or neck. And that makes sense for acute pain. It makes sense if we're looking at an abscess or a broken bone. But when we apply that same model to chronic pain, that can actually lead to ineffective treatment, worse outcomes, and even potentially harm. So now if we widen our focus, instead of looking at the elbow, we're shifting to looking really not only at the whole person, but also the environment that person is in. So this type of evaluation is much more appropriate for chronic pain. We know that psychiatric conditions like depression, anxiety, social isolation, or otherwise unhealthy relationships, PTSD, medical comorbidities, obesity, sleep problems, diabetes, and even things like lack of purpose in life can influence functional outcomes related to pain. In terms of life purpose, that can even influence overall mortality. We've heard about terms of red flags, and we're very kind of comfortable with those in a primary care environment, thinking about potentially dangerous pathology. And if we have a red flag that indicates potentially dangerous pathology, we need to work that up further. I want to introduce a term and talk about yellow flags. So yellow flags we talk about are factors that increase the risk for a person's having poor outcomes related to pain or increased disability related to pain. And so widening our focus to include those yellow flags that we talked about earlier is really critical. And then also recognize that once we widen that view, that also opens up many more effective treatment options for us. So next we can think about where is our therapeutic focus. So if we kind of move along this slide here, we can think about, are we focusing just on a pill and medications, and that's really our focus, either increasing or decreasing or doing something to the pill? Are we focusing on a pathology? Are we focusing on an MRI finding? Or are we having a larger focus and, again, focusing on the whole person? And Clearly, that's really where we want to be. And having a narrow therapeutic focus either on the medication or a specific disease body part or pathology can not only jeopardize the relationship, but as we'll talk about further, can actually lead to more harm than good. So now diving into looking at Susan and how do we treat her as a whole person, we can really think of starting with a focus on the therapeutic alliance and building rapport, building that relationship, knowing that really everything else that we do will depend on the strength or relative weakness of that alliance. Starting by things like validating her experience of pain and suffering. And sometimes we think we're hesitant to validate because we think that if we validate, that means that we may have to prescribe an opioid medication, for example. And so I want us to really recognize, and I know Beth, you'll talk more about this, but recognize that we can absolutely join and validate our patient's suffering. And if we think opioids are not a safe option, then we can talk about other options. But starting with validation there is very powerful. Learning about her health and life goals. So again, widening that focus and away from just talking about a pain level to what's important to her, what would she like to be doing more of. Also treating the whole person means not just looking at that elbow or the back, but are there other comorbidities? So Susan has several comorbidities that we can treat. We know that simply focusing on increasing physical function, not so simply, but focusing on treating depression and using evidence-based treatment for depression and insomnia can improve a patient's experience of pain and improve function. Next, I want to move into talking about a series of articles that was published in The Lancet by the Low Back Pain Working Group. There were 3 articles. The first article talks about, well, what is low back pain and why do we need to pay attention for it? All of these articles really talk about a transformation in pain care. So the key messages for that first article was really that, just like Beth was talking about, that low back pain and pain in general is a complex condition with multiple contributors. Right? So we've talked about that. Hopefully this is sounding familiar. And that for the vast majority of patients with low back pain, it's not currently possible to accurately identify a specific nociceptive source, i.e. a pain generator anatomic source that's causing the pain. For the second article in that series, they talk about prevention and treatment of low back pain. And the key messages for that article, again, hopefully you're sounding familiar, are using a biopsychosocial framework to guide management and really focusing on initial non-pharmacologic treatment. We know that there is good evidence supporting giving our patients education to support self-management and the resumption of normal activities. The flip side of that, there's evidence that recommending rest can actually be harmful. Furthermore, there's evidence that exercise, engaging in really any type of regular movement, increases health and can help a patient's pain and function with low back pain. And then for those patients with persistent symptoms, which are many of the patients we're talking about, looking at psychological programs that we'll talk about in a little more depth later on. Finally, they talk about avoiding harmful and useless treatments. So we have programs for drug regulation, medication regulation, such that really we only use medications and we have prior authorizations, things like this. We use the medications that have evidence of benefit, are safe and effective and cost effective. And so really transitioning our view of treatments for low back pain to a system like that. And unfortunately, non-evidence-based practice is common, so including an inappropriately high use of advanced imaging, recommendation to rest, opioids, spinal injections, and surgery. Then the final article here is really a call to action. The key messages to that manuscript are shifting again from a view only looking at pain to what they called a positive health view. So we can also think about this as resilience, the ability to adapt and to self-manage in the face of various challenges, social challenges, physical and emotional challenges. And then really working to address these widespread misconceptions that we've talked about the causes of back pain, the prognosis, and the effectiveness of different treatments. So what does this look like now as we move through with Susan? So looking at treating her as a whole person, treating her comorbidities we know can be effective for chronic pain. She's on 150 MEDD, so a high dose of opioids that's been associated with adverse outcomes, but she's resistant. And so certainly a great place to start is by providing some education about the potential harms, about some of the changes in the brain that happen with opioids, talking about potential for worsening mood. There's some studies that show increased likelihood of actually developing both depression and treatment-resistant depression, irritability, and sleep disruption. So providing her that education is a great place to start. Then starting to look into the risks and benefits of her current therapy versus the risks and benefits of opioid deprescribing. Then finally, whereas you may or may not make a change initially with her, we want to introduce the concept. So even if we don't make any changes, we can introduce the concept of minimizing reliance on opioids in the long term as we begin to work with her. And with that, I'll turn it back over to you as we, Beth, and kind of start to look at how opioids affect the brain and body.
Yeah, thank you, Aram. I love that series that really walks us through all of the conceptualization about how to best treat pain at lowest risk. And, you know, when we talk about opioids and we're talking about opioid deprescribing, a key truism is that fewer new starts is the best way to decrease opioid prescribing. And the 2016 CDC guideline on opioid prescribing really spoke to new starts. That guidance was never intended to inform opioid deprescribing in any way. Patients who've been taking long-term prescription opioids require very careful considerations, whether they remain on opioids or whether those opioids are deprescribed. Over the long term, we see that there's physiological and neuropsychological adaptations that have occurred, and that this creates some vulnerabilities, so that even within the context of opioid reduction, there are new risks that are created. And this is a really important point. There's a common perception that less opioids is always better for patient health. But in fact, new data reveals that new health risks emerge during opioid dose changes during a deprescribing situation, and that right methodology can be applied to minimize iatrogenic risks from deprescribing. This is really the core of this webinar, is how to minimize health risks for patients through this lens of deprescribing. And we see that over about the past year to year and a half, this issue of iatrogenic risks and harms from opioid reduction has received some intense focus. Early on, with these calls to deprescribe opioids, there was quite a rush to reduce dose, largely out of a perception that less is better. So that if patients are at risk for opioid overdose with higher doses of opioids, we need to quickly get them down to quote unquote safer levels. But what was revealed in some of the patient experience and data was that, in fact, without right methodology being applied, patient risks are increasing. And those are risks for overdose, for patient distress, patient suicide even. This issue created some outcry from multiple healthcare clinicians within the United States and outside the United States. Human Rights Watch published an article on this topic calling rapid and forced opioid tapering a human rights violation. We see that the FDA and the CDC got involved in mid-2019, issuing cautions and clarifications and calls for patient protections, calling against abrupt opioid discontinuation, and ultimately, this culminated in October of 2019, Health and Human Services publishing some opioid tapering guidance, which Aram and I will be referring to throughout the webinar, and it is also a component of the PDF resource attachment that accompanies this webinar. So when we're talking about these dual crises of pain and opioids, you know, the question, of course, arises, how do we best help our patients? In the early days, it was a pill for everyone or a pill for most, and that led to a lot of inappropriate prescribing. And in the climate of calls for opioid deprescribing, there's been a rapid push for less pills for everyone or no pills for everyone. And what we see is that in either direction, there have been harms caused to patients. So that rather than focusing on the pills themselves, what we need is a truly patient-centered approach. We really need to carefully attend to the needs of each individual to best assure that we're tapering the right people and in the right way. This is of major consequence, as I mentioned, with recent data suggesting that 11 million Americans are taking opioids. This recent data suggesting that there is increasing trends around tapering, that this particular study evidencing that 23% of patients reporting opioid tapering in the last few years, and this was up to 2017, so we suspect that that percentage is even higher now. So there are a lot of patients in the United States right now being tapered, having their opioid prescriptions reduced, and some of the clinical applications have gotten ahead of the science on this topic. So we have seen that there has been data suggesting mortality, increased mortality related to opioid discontinuation, and needing to pay very careful attention to these risks that, again, less opioids, not always better, and in particular, the methods by which an opioid taper is conducted matter greatly, because those methods can either assure careful patient protections and the implementation of patient-centered care, or they can unwittingly cause patient harm. So we have seen a host of potentially negative outcomes or iatrogenic harms following opioid tapering and discontinuation, including increased suicidal ideation, increased suicide, and we have seen increased opioid overdose occurring within the context of opioid reduction. this really challenging that common misperception that if we simply reduce opioids, patients are safer. In fact, this last study, the first author, Jason Glanz, showing that it's really the opioid dose variability, whether we're increasing opioids or decreasing opioids, but it's the change in opioid dose that confers risk for opioid overdose. So always want to be mindful of that piece. And we have many different bits of wisdom and clinical strategies to help with this process, to help you best identify who's right for opioid tapering. And then as we move forward to implementation for those patients for whom opioid reduction is the best pathway, how do we help keep them safe? And help them have the smoothest process through opioid tapering. And Aram, I don't know if you wanted to add any other thoughts to this sort of, little body of data that we have at this point that's really raising yellow and even some red flags for opioid reduction.
Yeah, thanks, Beth. This is, if we look at the publication dates on these are all in the last year. We're going to, more studies will come out. So this is really kind of the first bit of data that's starting to emerge. I really like how you highlighted, and it's so important to recognize these neurobiological and neuropsychological changes that occur with long-term opioid use. I think partly how some of the large increases in opioid prescribing started was basically not recognizing those neurobiological, neuropsychological changes, such that 25, 30 years ago, it was really thought that we could start opioids and we could stop them relatively easily, like other medications. And so I think that's not only why new starts were more common in the past, but recognizing that also is critical in helping us recognize that patients that are already on opioids, this is a different population that we need to look at differently. We need to really look at as a vulnerable population and bring in extra caution. And we'll talk about those neurobiological changes more in the future. And then just one more point on some of these articles that you were highlighting here. I think I'd just like to highlight the importance of screening for mood disturbance and suicidal ideation in this entire population. So in the VA, screening for suicide is universal. And I would highly recommend, really in any clinical setting, for patients with chronic pain, and definitely for patients with chronic pain on long-term opioid therapy, to screen for mood disturbance, suicidal ideation, and then make sure that in the clinical setting, you have the systems in place to manage those patients if those screens are coming up positive. And then. Sorry,
oh, yeah.
Sorry. One last point here. So we'll touch on this again, but I thought I would just bring it up. So recognizing how important it is to maintain close contact with these patients. So not only while we're prescribing opioids, so a patient who you may not be making any opioid dose change on, we need to be following regularly, and the CDC guidelines provide some guidance on that. We'll talk more about the specifics, but bringing that same close contact to situations of opioid tapering, and may even need to increase the degree of psychosocial support during a taper. And then another vulnerable time is if opioids are discontinued for whatever the reason is, that period of time after opioids have discontinued, we need to make sure that we don't discontinue care or discontinue the frequency of contact, but we have the same or maybe even intensify the level of follow-up and support in that time period.
Yeah, I love that. And your points are so well taken that part of applying these right methods really includes this very close monitoring, bearing in mind that the health of the patient is really paramount. And once we appreciate that the health risks are amplified during dose changes and even after discontinuation, so that we really do need to assure that we have close contact with patients as these continual neuropsychological and neurobiological adaptations are taking place to opioid reduction, so that we can monitor for new symptoms, new crises that may emerge during this time frame. So I just want to highlight, again, the tapering methods matter greatly. So what we've seen is that historically, over the past couple of years, there have been some rigid dose-based policies. We got to taper you to this dose or that dose. We see that those types of policies really are a violation of patient-centeredness. We want to focus on each patient as an individual, recognizing the individual differences in the experience of pain, in their response to pain treatments, and their response to opioid reduction. So if we fail to appreciate the individual experience across all of these domains, we are unwittingly exposing some patients to health risks. This has been recognized by the CDC and the American Medical Association. And so there's really sort of a broad push against rigid dose-based policies in terms of opioid prescribing and a certain dose threshold that we need to focus on. We need to recognize that dose changes in either direction are associated with health risks. We can apply patient-centered opioid reduction methods to enhance patient engagement, safety, and their outcomes. So this is really where we're going to, Aram in particular is going to focus on screening, appropriate screening prior to tapering to ensure that you're tapering the right patients. We will be emphasizing voluntary opioid tapering methods, and then give you sort of a framework for how to carefully monitor your patients. And then, as Aram mentioned, the extent to which you can, to the extent to which resources are available to provide your patients with psychological support during the tapering process and beyond. So within that framework of, our perspective, okay, opioid dose changes confer risk. How do we minimize those risks? And how do we create a sense of safety for our patients? So what we really need here is to apply the biopsychosocial lens now to opioid reduction. We talked about previously the biopsychosocial model of pain and pain treatment, but now we need to apply that here to opioid reduction. And, this topic of opioid reduction has been quite vexing for many. How do we best do this, and how do we best engage patients, and how do we get best outcomes? What we know is that when we taper the wrong way, either when we're reducing opioids too aggressively or in a forced manner, we see that there is increased risk for a whole host of negative outcomes, including withdrawal symptoms, patient distress, failed tapers, remaining on high doses, overdose, suicidal ideation, and even suicide we have seen. And when we talk to patients about opioid reduction, unsurprisingly, their number one concern and fear is increased pain. And this makes sense because, they were prescribed opioids to reduce their pain. And now we're telling them that we're going to take away that medication. So, of course, their first question is going to be, well, what are you going to do for my pain? How am I going to manage my pain without my pain medication. Now, interestingly, what we see when we take a look at the data for opioid reduction, we see that when opioids are tapered the right way, we see that pain doesn't actually increase when opioids are reduced. We see that on balance, pain typically improves. Now, notice that I said when opioids are tapered the right way. So this is a VA study that involved interdisciplinary, intensive care where patients were receiving a whole host of services as part of inpatient treatment. Now, this is the type of wonderful, intensive pain care and opioid reduction care that none of our patients receive, really and truly. And of course, we're talking about low resource settings. We're not talking about what's possible in, this mythical setting, but it is important to recognize that when opioids are tapered the right way, our patients do get nice outcomes. But this is what's missing. We really need these community-based solutions so that we can help clinicians such as yourselves be able to implement effective patient-centered opioid reduction in a low-cost manner that's scalable, that reduces patient health risks, addresses the anxiety of patients and prescribers alike, and that promotes this good clinician-patient bond. Because what we have seen and what you may have experienced yourselves is that there can be an adversarial relationship that evolves, a struggle around opioids that can really undermine this therapeutic alliance that Aaron was mentioning at the very beginning as being so critical to patient outcomes. And so if this adversarialness, this struggle around opioids interjects itself into the therapeutic environment, it can truly undermine this clinician-patient bond, the therapeutic alliance that is the foundation for our patient outcomes. And it will necessarily negatively impact patients' willingness to even engage in a gentle opioid taper. So this was an issue that we sought to tackle a few years ago. And this article that you see here, this research letter was published online last February and in print form last May. It is appended in the resource attachment that accompanies this webinar, so you can see this study and the actual data. But what this study was about was applying patient-centered methods in a low resource setting, the types of clinical settings that many of you are practicing in right now. So this was conducted in the Denver area as well as in rural communities in Colorado. And the situation was that we created methods, patient-centered methods for opioid reduction that involved clinicians and patients working in a collaborative manner, co-creating a gentle opioid reduction plan. So this was targeting all patients taking daily prescription opioids. And we did not discuss opioid stoppage or opioid cessation with any of the patients. What we said to them was, we are inviting you to join a patient-centered opioid reduction study in which we will work collaboratively with you to gently reduce your opioids to your lowest comfortable dose over a 4-month period of time. And this was a really important distinction, because if we talk about opioid stoppage, that concept can be so overwhelming for patients. So really helping patients just think about things one step at a time. We're just going to do a trial, we're going to observe how you do, and we're going to help you feel and be in as much control as possible throughout the process. So we really and truly optimize patient choice and control in their taper. First of all, their participation in this study was voluntary. We didn't force anybody to join the study. Patients could control the pace of their taper. We started out with almost what I call microdose decreases. They're almost psychological dose decreases in the beginning, just to help address patient anxiety around opioid reduction and to help better manage that so that they can begin to trust the process and trust their bodies that they can actually do this without being overwhelmed by increased pain. So patients were free to drop out of the study anytime if they wanted. The goal was not 0 unless they chose that goal. And the taper was not to a predefined dose. Remember, we just said to achieve their lowest comfortable dose over 4 months. And importantly, the taper was not unidirectional. And what that means is that if a patient had surgery, if they had an injury, if they needed additional opioids, we allowed for that. So that was important. There was flexibility in the process. So in this study and across several clinics, we invited 110 patients to join this patient-centered opioid reduction program. And out of those 110, 82 said that they would participate. And that sounds like a phenomenally high rate of engagement. In fact, 68 actually joined our study. Which is still a pretty phenomenally high rate, but again, it was voluntary and they could stop anytime. So we allowed them that comfort and safety, so they were more willing to engage with us. And so of those 68 patients who joined this study, the setup is that while they worked with their doctor over a 4-month period to slowly reduce their opioids, they were meeting with their doctor about every 3 weeks. They could also have more frequent visits if they wanted, and telephone visits were allowed. We collected their data at 2 time points, at baseline and at the end of the study at 16 weeks. We did not offer them psychological support per se because we were unable to operationalize that in this clinical setting. So the psychological support that we offered was our actual tapering methods themselves, which allowed patients this high degree of control and safety. So we were actually treating their anxiety and going at their pace and working with their bodies to assure best adaptation through the process. So we sort of infused the psychology into the study itself. But the point I want to make is that they weren't working with a psychologist outside of their taper. So I mentioned that 68 patients joined the study. I'm only going to present data for you for the 51 who completed this study. 17 patients dropped out of the study. This is a 25% attrition rate, which is relatively low, considering pain treatment studies. That's a relatively normal attrition rate. But we wanted to understand what distinguished patients who dropped out of this study versus those who remained in the taper. And there was only one factor that distinguished patients. People who dropped out of the study were much more likely to have higher levels of depression at baseline. And this is a really important point. Because the patients with higher levels of depression were self-selecting out of the taper. And I just want to bring our awareness back to some of those cautionary data that are emerging, showing increased rates for overdose, for suicidal ideation, and for suicide within the context of directed opioid tapering studies. So the data that I'm going to present to you are important for two reasons. Number one, patients with higher levels of depression, again, are telling us that there's something about the taper process that they're not able to participate with. These are a really special population. They need a higher level of care. We offer strong cautions against moving forward with opioid reduction in this patient population without very careful attention to their needs. So I can't tell you right now with certainty what those needs are, what we need to do to help them. Whether, do they need inpatient care? Do they need close psychiatry follow-up? Psychological follow-up? Do we need to simply stabilize them on opioids? We don't yet have data, but what we do know is that we should apply extreme cautions when conceptualizing this vulnerable patient population. And I know that Aram is going to talk in greater detail about what we can do to better support them, and whether this is taking a longer period of time for them to adjust, recognizing these neurobiological adaptations. And we'll also be talking in some depth about how to best assure cautions in patients for whom opioid reduction is absolutely essential, and we see higher levels of depressive symptoms. So we will have more to say on that topic. Right now, I just want to draw your attention to this patient sample where we see that they've been on opioids a long time, on average 6 years, but a range of 1 to 38 years. We see that 37% were also using marijuana. This was in Colorado, where marijuana was legal. And we see that the morphine equivalent daily dose, almost 300. So this is a real world sample of patients. These are not patients who are being, cherry picked for low doses, though there is some cherry picking for having lower levels of depression, because again, those with higher levels self-selected out of this study. And what you see here, we just compared baseline to 16 weeks. And what we showed was that patients applying these methods, that on average, patients were reducing their opioids about half over this 4-month period. Now, some patients, of course, reduced much more than others. We had multiple people who actually tapered to 0 over the 4-month time period, 16 people who tapered below 90 milligrams. It was individualized and going at their pace. So paying attention to the individual differences. These data slides are showing you the variability here. Each dot that you see is an individual patient in this study. And what we were interested in understanding here was whether the initial opioid dose predicted patient response to the taper. And what we found was that it did not. So what that tells us is that even patients on relatively high dose opioids were equally likely to reduce their opioids over the 4-month time period. And then this next slide is the one that everyone's really interested in. Well, what happened with patients' pain? And what we found was that on average, pain did not increase as patients were decreasing their opioid dose. And for some patients, their pain actually improved quite substantially. But here's where I want to draw your attention, is to some of these outliers, because not everybody's pain improved. So if you look on this data slide, if you look at the lower right-hand corner, you can see that for some people, their pain increased. They weren't huge increases in pain, but I really want to draw our attention to this fact and caution us against having sort of just broad swath labels that opioid reduction always improves pain. It does for most, but not for all. And that's why it's important to apply patient-centered methods and try opioid reduction, but recognize that it's the individual response that should really drive our treatment plan during the opioid trial. The last thing I want to bring our awareness to on this slide is that notice that some patients actually increased their opioids, at least 3 did. Those are the red dots. And so I can't tell you why they increased their opioids, whether there was a surgery, whether there was an injury, or whether it was just their chronic pain. But we did allow for dose increases, and that did occur for some of our patients. So yet again, important to be mindful that one size does not fit all in opioid reduction. And that's just a key takeaway from our time together on this webinar. One size does not fit all. And so how do we tailor this to the individual to best assure that they get great outcomes for tapering and very broadly for health? So for this vignette, I'd just like to note this is Beverly, and she is a patient who is a church volunteer. She's quite functional. She's been watching her grandchildren after school. This is a huge service to the family and her children that she's able to watch the grandchildren. It brings her great satisfaction. She's been stable on opioids for 8 years for widespread pain and rheumatoid arthritis. And what she has observed, she was reticent to trial opioid reduction, but she agreed and she engaged in opioid tapering. And what occurred through this opioid tapering trial was that Beverly found that her pain increased. She was no longer able to watch her grandchildren. She wasn't able to engage in the things that gave her pleasure and her life meaning. And of course, this was negatively impacting her mood. Her response to the taper, now this is assuming the taper was implemented in the right way, of course, but her response to the taper gives us some pause, because she was quite stable for a number of years, relatively high functioning, doing well, no yellow flags, no aberrant behaviors, no red flags. And so this is where, when we're applying this lens of individualized care, we have to consider that this might be a case for a patient who's, should be on some level of opioids and may need to go back on her doses. So always within the context of patient-centeredness, having that on the table, that opioid reduction is not right for everyone. So I just want to bring that to our attention. And Aram, I don't know if you'd like to say a few words there before I move on into the Empower study.
Sure. Yeah. Thanks, Beth. So this is a tough case, and I think one of the things that it illustrates, as well as what you were talking about before, is this need to. So as you talked about, not applying a one-size-fits-all, and kind of the flip side of that is being flexible, adaptable, frequently reevaluating our patients. I sometimes talk about what I call a now/forever fallacy, which is sometimes this trap we get ourselves into where we make it a treatment decision now, and whether that's a decision to taper or not to taper, we sometimes maybe not consciously, but sometimes think about that as that's a forever decision. I'm gonna keep them on opioids or I'm going to taper and I'm just going to move forward with that plan, is kind of my forever plan. So this case really illustrates the importance of why we need to be cautious about that. And if we make a plan to taper and it's not going well, our frequent reevaluations will help us catch that, maybe pause, maybe even go back to another dose, maybe, as we'll talk about later, assess for other conditions that we can treat, like opioid use disorder, and then change our treatment plan accordingly. I think that just really, the case nicely illustrates the importance of frequent evaluation and being flexible and able to change our treatment plan as needed.
Yes, thank you. And, of course, we're not just interested in helping our patients reduce opioids for the sake of reducing opioids. Ultimately, we're focusing on their health and helping our patients do more, live better within the context of some very challenging and complex medical conditions. So the National Pain Strategy, the Institute of Medicine, the CDC, multiple government agencies have really called for opioid deprescribing, and they have called for better integration of behavioral medicine strategies and self-management strategies to facilitate the goal of opioid reduction. And to sort of answer this call and extend our findings from that prequel study that I just described, the one in Colorado, we are now conducting a large-scale study. This is funded by the Patient-Centered Outcomes Research Institute, or PCORI. This study is Effective Management of Pain and Opioid-Free Ways to Enhance Relief. This is Empower. And it's a comparative effectiveness study of 2 behavioral medicine strategies being applied within the context of voluntary opioid reduction. And Aram is also participating in this study. He is the site PI for the Phoenix VA, and I am the overall principal investigator for the Empower study, being a 4-state pain and opioid reduction study. So I mentioned that we are integrating in behavioral medicine strategies, those being 8 weeks of cognitive behavioral therapy for chronic pain, or 6 weeks of the chronic pain self-management program. Now, our patients are randomized to these treatments. So essentially, we're applying those same prequel study methods where we work with patients to help them want to engage with us, to be willing to try an opioid taper. We enhance patient control over the pace of their taper. They can pause the taper if they wish to, and they can even drop out of our study if they want to. We also optimize their expectations for a good experience with opioid tapering with our program. And for those patients who agree to enroll in our study, they are randomized to receive either one of our 2 behavioral treatments, or they just get the taper only. And this is essentially the Colorado study, which we showed helps patients reduce opioids. And we found in that study that mood didn't worsen, anxiety didn't worsen, pain didn't worsen. So what we showed in that study was that you can reduce opioids if successfully without having deterioration for patients if these patient-centered methods are applied. But we're testing the added benefit of behavioral medicine because we do hypothesize that if we give our patients some skills to self-regulate, to control their experience, to enhance their self-efficacy, to self-manage their pain, that they'll do even better as they're reducing opioids. Now, patients who enroll in the Empower study, they're in our program for 1 full calendar year. So we are conducting this study in almost 1,400 patients in California, in Utah, in Arizona, and in Denver. And we're tracking our patients very closely throughout the study. Almost anybody is eligible as long as they're taking at least 10 milligrams of opioids daily for at least 3 months. But we don't have a ceiling on the dose either. So we have some very high dose patients who have enrolled in Empower. We have minimal exclusions because we're aiming to collect real world data to inform national pain care for opioid reduction. So we only exclude for active suicidality. This is really important. We do exclude for moderate to severe opioid use disorder. Now, and after I finish this section, Aram will be describing in detail the methodology for screening the right patients. Patients with moderate to severe opioid use disorder require a different care pathway. So for Empower, for this community-based outpatient opioid tapering program, we do enroll patients with mild opioid use disorder, but not beyond that. So I will allow Aram to talk about our screening methodology. And here I just want to note that a big part of Empower is infusing the education among our clinicians about how to best engage patients, how to partner with them in a collaborative care agreement for opioid reduction, how to leverage the therapeutic alliance to allay patients' concerns and fears. You have a lot of material about these methods in the PDF resource attachment that accompanies this webinar. We have tips and scripts, and we have also appended articles that talk about extinguishing nocebo for opioid tapering, and that exists in your packet. Aram, I don't know if you want to say a few words of wisdom about how clinicians are engaging with patients to enhance receptivity to trying an opioid trial.
Yeah. So yeah, I think really everything you've covered has been excellent, and it's been, that's been the goal of our clinic for a few years. However, bringing in the Empower trial has really allowed us to think very deliberatively about how we do that. I really recommend to the webinar participants looking at the article on placebo and nocebo, and enhancing positive expectations and extinguishing negative expectations related to opioid tapering. I really like you talked about those microdose changes, and we absolutely use those. So we'll often make no changes initially when we're first meeting a patient, and really just establishing rapport. And as we've talked about, just helping the patient understand that, our goal is to help them function better, is to help them improve life, and we're not just focusing on the pill. So sometimes that means just taking over prescribing at the same dose. And then really, as you talk about collaborative tapering, we like to use things like asking our patients, well, what would you like your taper to look like? And what we've really found is if our patients can come to us with a plan, and some of our patients bring in spreadsheets, engineers, like they brought in like fully detailed tapers, some of them less so. But what we found is if our patients have that level of buy-in and can develop even a broad sense of what they want their taper to look like, even if they're coming on higher doses, and even if they want to taper a little quicker than we would recommend, they often they do well. And that's contrasted to even if we make a very small change in an opioid dose for someone who is not interested and has zero buy-in, they, even with a almost non-physiologic dose change, can report that they're doing worse. And I think I love that you brought in that Irene Tracy study. It really just illustrates, that what that study showed in the lab that we're seeing in clinic. So, yeah, we've enjoyed and kind of have been refining some of those strategies over time.
Yeah, terrific. No, so important to really be mindful of our patient expectations, and so having those very tiny dose decreases up front, I always call them almost cosmetic dose decreases, because again, we're really just addressing patients' fear and anxieties. And then a big part of that as well with taper success is addressing any discomfort as early on as possible, so that because by extinguishing that discomfort, we're also helping them return back to a place of less distress, greater comfort, and that facilitates their ongoing engagement in the taper. So these are some philosophies with Empower. Our guiding principle is that we must create a caring and safe system that makes patients want to join and remain in Empower, because remember, it is voluntary. So one of the ways in which we do this is that we monitor our patients very closely. We happen to use an electronic system to do this. And I know that those of you who are listening on this webinar do not necessarily have access to this type of technology, but we will, after describing the ways in which we're collecting this data, you'll learn that you can do this yourself, even in a low-tech environment. But what we're doing at each step is we're understanding not just what a person's pain score is, but we're assessing them across a range of different dimensions. So we're looking at mood, anxiety, functioning, etc. And we're doing this over time. We use this system in the Empower study, where we apply a pretty deep survey at baseline 6 and 12 months. And importantly, at baseline, at enrollment, we're asking patients the degree of choice that they feel in their opioid taper, and we're also rating their readiness to taper. We believe that these are two important indicators that that sort of get at this concept of, we want to work with patients and make this patient-centered. So if patients are willing, and if they're ready, and if they're participating as a partner, they're more likely to achieve better results. And while we haven't done head-to-head comparisons, we do see some in the early data that we have. We see that when we apply methods that enhance choice and readiness, we see our patients doing better with tapering relative to patients who have less choice and who are not ready. So this is important. Lastly, down at the slide, you'll see that we survey our patients weekly for withdrawal symptoms and mood, and we're also assessing for suicidality. So you may not be able to deploy surveys to your patients, at this level of frequency. But what we unequivocally do recommend is that while your patients are tapering, that you monitor patients very closely and have systems in place so that patients can communicate with you or your clinic staff when they are experiencing discomfort, and that there's some plan in place for how to address that. So whether that means pausing the taper, or whether that means prescribing an adjuvant medication to allow for some better symptom management, whatever that is, and also surveying patients, asking them, how's your mood, giving them some plan for how to address increased depression or any thoughts of suicide should they emerge. So Era mentioned that in the VA, they survey patients very closely. So if you're not doing that now, we do recommend in this patient population to best assure safety that you integrate in these measures and also have plans in place that you communicate to the patient so that on the weekends or whenever, after hours, they know what to do if they find themselves in trouble. So with Empower, with our electronic systems, our prescribers get alerts in real time. Patients get tailored messages for actions they can take in real time so that if a patient was suicidal, they would have clear action steps, a hotline they could call, 911, a clinic line, whatever it is, so that through the Empower study, they're actually receiving care. We're not just collecting their data, we're using their data and deploying a system that is responsive to their needs. And we're tracking patients over time for a full 12 months. We don't have enough good long-term data on our patients who have reduced their opioids. These are just some data displays so that you can see what we are able to see in Empower. So we're able to see for this patient who's reduced their opioids over 6 months, you see a substantial decrease in opioids. Their pain is remaining the same. But even more importantly, we're able to do a multidimensional assessment so that we're sure that even within the context of opioid reduction, our patients aren't getting worse. And that's critical. So what we see across a range of different outcomes here, we see that our patients are either static on these measures or they're actually improving. And so this, of course, being very important. We use peer-to-peer communication in Empower. So you can go to the Empower study website and we have video vignettes of patients with lived experience with successful opioid reduction. These can be powerful testimonials that you can use even with your patients to help them get a sense about how opioid reduction may be beneficial for them. So with that, we will now be moving to our next section where we're going to be talking about the nuts and bolts of patient-centered opioid reduction and applying this biopsychosocial model of opioid tapering, how to do this and put it into action. So with that, I will turn it over to you, Aram.
Great, thanks, Beth. So what we're looking at here is basically a screenshot of a very helpful document that's included in the packet here that I would highly recommend folks read. It's about, I think it's a 4.5-page document. This was published by Health and Human Services in October 2019, so just published. And it's a guide for clinicians on the appropriate dosage reduction or discontinuation of long-term opioid analgesics. This document talks about many of the things that you've heard on this webinar. So if you look at this and read through it, much of it will sound familiar. Cautions with opioid tapering, collaborative approach to tapering, and then the importance of applying appropriate treatment support for those patients who need additional support, such as those with mental health and substance use comorbidities. Now, they include a flow chart here, which is nice, and I thought we'd take just a minute to go over it. I have some thoughts about maybe rearranging some of the order of assessment, but this is a very helpful general schema to think about. So the schema basically starts with an assessment of risks and benefits, right? So if we're talking about who are the appropriate patients to initiate an opioid taper, this is a great place to start. So thinking about what are the benefits, what are the risks, and then weighing those. A little bit later down, we'll talk about some of the challenges with that and some other kind of concrete recommendations out of those challenges. So if we find that a patient is achieving benefits that outweigh the risks, then we want to carefully document that. And as we see over on the right side of this flowchart, basically continue with reevaluation and risk-benefit assessment on a quarterly basis. So this will often mean basically continuing that same therapy, but not falling prey to that now forever fallacy and continuing to reassess on a quarterly basis. Now, conversely, on the left side, where we see risks outweigh benefits, now we really want to start entering this collaborative taper process. So even when we're clear that this is the arm that we want to move down, as long as there are not immediate or impending danger of the opioid therapy, and what does that mean? Well, noticeable sedation, recent car accidents, maybe even a non-fatal overdose. Those are clearly situations that require more immediate changes to therapy. But as long as we don't have those sort of situations, what we want to do is generally err on the side of giving the patient time to get that buy-in that Beth was talking about, since we know that patients do better once we have that. And then as we develop that, initiate a slow collaborative taper. We still want to reassess risks and benefits and may need to adjust that pathway. We may need to pause the taper. Sometimes we might, very commonly, we might slow it down. Occasionally, if a patient wants to increase the pace, we can do that as well. Now, if a patient is not doing well during that process, we in this flowchart, we're assessing for opioid use disorder. Now, another thought is to really screen and assess upstream of all of this, because if we do identify opioid use disorder, we really are looking at a different treatment pathway. But at any point in time, if we're identifying opioid use disorder, then over on the far left of this diagram, we're really needing to move to looking at evidence-based treatment for opioid use disorder, which are medications for addiction therapy, or MAT as an acronym you may hear. Buprenorphine can be used in an office-based setting, and you do need a DEA or data waiver to prescribe buprenorphine for opioid use disorder. If a patient does not meet criteria for opioid use disorder, we're on the right-hand side, but is struggling with a taper, another option, which is one tool in the toolbox, is to use buprenorphine as a tool to rotate the patient to and then gradually taper that buprenorphine. Now, if you are prescribing buprenorphine for pain and not for opioid use disorder, so again, this is a patient who does not meet DSM-5 criteria for opioid use disorder, a data waiver or X waiver is not required. So any provider who is able to prescribe Schedule III controlled substances would be able to prescribe buprenorphine in that situation. Okay, so we'll dig down and start to talk about some of the details here. So again, a general note of caution and thinking about both our patients that are on long-term opioid therapy and also our patients who are tapering as vulnerable populations. So from, in our next slide, also from the HHS document, who are we thinking about tapering? Well, here's a list, and we're not going to go over all of these, but again, if pain is improving, if a patient comes in requesting a dose reduction, if pain and function are not meaningfully improved, so going back to that flow chart, risks outweighing benefits, if there's evidence of opioid misuse, if there are side effects that the patient's experiencing that are really impairing their quality of life or function. Clearly, in the case of a serious event such as a non-fatal overdose, sedation, these are situations where we need to think about a taper. Patients that are on another sedating medication, such as benzodiazepine, or have other medical comorbidities, such as obstructive or central sleep apnea, chronic lung, liver, or kidney disease, we should also think about as those situations increasing the risk and think about a collaborative taper. Moving to our next slide now. So when we're thinking about risk and benefit, unfortunately, that's often not possible, right? If we have inherited a patient or a patient's been on opioids for a long period of time, we don't have a good mechanism of assessing benefit before the opioids and at the present time. And so that risk-benefit assessment at that point becomes more complicated and is not as simple as sometimes it might sound. So a proxy for having a multidimensional assessment before opioids were started and after opioids, after a patient is on opioids, is looking at the current level of functioning. And again, a broad level of functioning. And so not just looking at pain intensity, but looking at social, vocational, emotional, physical function. And that multidimensional assessment at the current point in time may be our best proxy of determining how our patient is doing on the benefit side of the equation. If that level of functioning is low in multiple domains, then we can assume that we're not seeing real significant benefit on improving pain or function. And then we can switch to a risk assessment. So essentially looking at and trying to determine the risk that the patient's current therapy is posing versus the risk of tapering. And so we've talked about how we may have assumed in the past that, well, if opioids cause risk, then getting rid of the opioids must improve the situation, improve the risk. But as we've talked about, that's not necessarily the case. So comparing the risk of the current therapy versus the risk of tapering. Now, looking at our next slide with the factors that increase the risk of adverse outcomes on opioid therapy, we know that having both mental health and medical comorbidities and substance use disorder comorbidities appear to be some of the most significant factors increasing an individual's risk of having adverse opioid-related outcomes. And then certainly having a recent opioid overdose increases risk. Concomitant use of benzodiazepines and now emerging some other sedative medications. Not adhering to the safety monitoring that's being recommended would increase risk. Having a high prescribed dose has also been identified as an independent risk factor. The high prescribed dose may also be a marker for having mental health and substance use disorder comorbidities. So certainly we want to remain vigilant in those patients on higher doses for those type of conditions. And then finally, non-participation in a whole person pain care plan would increase our risk. Now, on the next slide, I'm going to come back to an article that Beth mentioned earlier. And this is a fascinating article published in 2019 in JAMA, showing, again, that both dose increases and decreases within a preceding 3-month period increased the risk of an overdose event. So recognizing that that dose variability within a 3-month period increases risk. So again, going back to the concept of with dose changes, we want to increased contact with the healthcare team, that may be with the prescriber, but often it's with another member of a team. If possible, if there's a nurse on the team, that's fantastic. Even a medical assistant, certainly if there's a behavioral health provider on the team, that can be very helpful as well. Another interesting nuance of this study is that for patients that actually had sustained discontinuation, meaning they had a 0 prescribed opioid dose for 3 months, for the 3-month period, there actually was a decrease in overdose risk. So again, a lot of these data are emerging, and I think the bottom line is we need to be cautious with this group. Next slide, we're looking at what are the factors now. So if we talked about factors that increase the risk on the current therapy, what are the factors that increase the risk of tapering? And we still certainly need more data here, but many of the things Beth has talked about, so a rapid taper. Many times in our clinic, we may see a patient who has been tapered rapidly, and maybe a 50% reduction or even a 25% reduction. They're having withdrawal symptoms. They're experiencing maybe worsening of an underlying mental health condition, or just severe distress. So those are certainly situations that can increase the risk of a taper. Lack of communication with a patient. So, for example, making a dose change and saying, "I'll see you back in 3 months." That can certainly, or longer, that can certainly increase risk potentially. Applying a one-size-fits-all approach, so not bringing in that flexibility of assessment and changing a treatment plan as needed. And then not recognizing or addressing mental health conditions. So a patient may be essentially treating distress from a mental health condition by the use of opioids, and may have been avoiding contact with mental health teams. And so absolutely, during a taper, we need to remain very vigilant that some of those symptoms may become more apparent, and we need to connect our patients with evidence-based treatments. And then also, as we'll be jumping into more detail, not addressing opioid use disorder or other substance use disorders. Now, we talked about some patients, even with a collaborative taper, may not do well, or patients who are resistant to making any change, even one of those micro changes. How do we approach these patients? Well, first of all, I think what's important, as we've talked about many times in the webinar, we need to think about this group as different than our other population, and different in that we need careful consideration, we need thoughtful approaches. As long as there's not immediate impending harm from opioid therapy, we often err on the side of giving more time. Now, we can think about a differential diagnosis for why a patient may not be doing well, why they may be resistant to a taper. Going back to those neurobiological adaptations, I'm going to talk about in a minute the continuum of changes that happen. So when there are more severe changes along that continuum, and opioid use disorder being the most severe, that may be a reason why a patient isn't doing well. It may be a reason why a patient is resistant. We talk about the gray zone, where a patient may not meet criteria for opioid use disorder, but they're manifesting more persistent withdrawal symptoms. And again, I'll talk about that in just a couple of minutes. Chemical coping, so a patient, again, may be using opioids to soothe emotional distress or even social isolation. Untreated mental health conditions. Diversion, we certainly need to be aware of and have policies for in our practice. Now, that's in our experience in some of the literature, that's less common than these other factors, but we still need to be aware of it and have policies for that. And our next slide, so that's our differential. Now looking at treatments. Our default we can think of is when particularly this higher risk population is not doing well, is if we're tapering, to pause and carefully consider our treatment options. If maybe we were taking over a patient who had a rapid taper, a 50% reduction, they're having withdrawal symptoms, we may then take over prescribing maybe somewhere in between the dose they were on originally and the dose that they came to us on that's producing withdrawal symptoms, maybe even back up to the dose they were on previously, so that then we can start a much more gradual taper. We've talked about screening for mood and suicidal ideation in all of our patients. For most of our patients in this group, looking at intensification of support. We're fortunate in our setting. We have an interprofessional team. We can bring in multiple movement specialists and psychological support. We realize that's not possible in the majority of treatment settings. So that intensification may be more frequent visits. And maybe if the provider is the only person on the healthcare team, then it may be increasing the frequency of visits with the provider. Optimizing treatment of comorbidities, as we talked about. So maybe if a patient has depression, if there's not, certainly we want to look for evidence-based psychotherapy if that's not available, using evidence-based medications such as SSRIs, SNRIs, the latter having some evidence of treatment for analgesic benefits as well. If there's opioid use disorder, looking for medications, looking at using medications for addiction treatment. And then finally, we talked about using buprenorphine as another tool in some of that gray area that we'll talk about in just a minute. So we've talked about, again, that opioid-exposed patients are different than opioid-naive patients because of these neurobiological changes. We, in the medical profession, we often think about if new data comes out that shows risks outweigh benefits, we do two things. One, we stop prescribing and stop initiating treatment. And then number two is we stop the therapy for people who are already on it. Now, as we talked about, that first option is probably where we'll make most progress and avoiding many new initiation of long-term opioid therapy. But that second part, because of these neurobiological changes, we need to look at differently. And whereas if another medical therapy, blood pressure medication comes out, and risks outweigh benefits, we just stop it and use a different one. We need a different approach for opioids. This next slide looks at this continuum of neurobiological changes. So on the one hand, simple physical dependence, and on the other extreme, opioid use disorder. Simple physical dependence basically meaning adaptations in the brain that have happened such that if we stop the substance, drug opposite effects will come out. So we call these opponent effects. So all of the opposite effects that an opioid would cause in the case of an opioid. And they're typically gone in several days or several weeks, and a patient basically feels back to normal. 30 years ago, we thought that the majority of people on opioids would have this type of neurobiological adaptation. Unfortunately, it doesn't seem to be the case. Many can develop the other extreme, opioid use disorder, where there are persistent changes in the brain that can last decades, if not the rest of someone's life. Potentially, we don't know exactly, but certainly persistent. We'll talk about what opioid use disorder is in a minute, but there is this gray zone for patients who don't meet criteria for opioid use disorder, but clearly have something more than simple dependence. And this is an area where, unfortunately, we don't have good data on, but in the clinic, we clearly recognize people are in this situation. In our next slide, we look at what is opioid use disorder. Well, the DSM-5 defines opioid use disorder as a problematic pattern of opioid use leading to clinically significant impairment or distress. Here's a key part also, manifested by at least 2 symptoms in a 12-month period. We'll talk about those symptoms in a minute, but it's important to recognize what opioid use disorder is not. So everyone on opioids prescribed opioids does not have opioid use disorder. The fact that someone has withdrawal symptoms when long-term opioids are stopped, that does not equate to opioid use disorder. A patient being worried about a taper does not mean that they have opioid use disorder. Or even having a high dose prescribed doesn't mean that they have an opioid use disorder. Having a high prescribed dose is associated with a higher risk, but it's not equivalent. So our next slide, we look at the 11 possible criteria for DSM-5 opioid use disorder, and we separate these into what we call the 3 C's. And I highly recommend everyone to really commit these 3 C's to memory. And these are loss of control, craving, and use despite consequences. Loss of control, craving, and use despite consequences. And we can see that there are additional symptoms under each of those 3 C's. And then we also have what we call physiologic criteria of tolerance, meaning as you increase the dose, if you've been on a medication for a long time, you've got tolerance, you're on the same dose, you have a lower effect, or you need a higher dose of the medication to get the same effect. And then we talked about withdrawal, meaning the drug opposite effects. If a patient is under medical supervision and taking medications as prescribed, then the physiologic criteria do not count towards a diagnosis of opioid use disorder. So that's key. So if someone is taking medications as prescribed, we're looking at these remaining 9 symptoms. And these can be trickier when we're looking at someone that's receiving prescription opioids under medical supervision. So, for example, the first one, using larger amounts or over a longer time period, coming to their regular appointments, maybe needing to kind of deal with some of the hassles of insurance doesn't count for using that I was talking more about our third one, spending a lot of time to obtain. Those sort of hassles wouldn't apply to that. Now, if a patient were going to multiple doctor offices, driving 12 hours to a doctor's office to obtain opioids, that is more what this criteria is looking for. So I highly recommend that folks have a slide like this, some sort of reference at your desk, at your ready to refer to, but certainly also committing those 3 C's to memory. Now, when a patient meets 2 or 3 of those criteria, they're diagnosed with mild opioid use disorder. If they meet 4 or 5 criteria, it's moderate opioid use disorder. Greater than 6 it would be severe opioid use disorder. So our next slide, we start talking about what do we do for our patients who are diagnosed with opioid use disorder. A great place to start is with a non-stigmatizing, non-judgmental approach for both the diagnosis and the medications used to treat opioid use disorder. Unfortunately, there is currently significant stigma associated with opioid use disorder. So we would do well to helping our patients recognize that opioid use disorder is a neurobiologic disorder with behavioral manifestations and components similar to a patient with type 2 diabetes. And so approaching our patients with the same way that we approach our patients with type 2 diabetes is an excellent place to start. Reassuring our patients that effective treatments are available, offering and encouraging medications for opioid use disorder, applying a whole person approach, and then intensifying our risk mitigation approaches. So things like our face-to-face visits, urine drug screens, checking the prescription drug monitoring program. We may need to intensify the frequency of those. There is strong evidence for using medications for opioid use disorder. On our next slide, we're looking at 2 Cochrane meta-analyses that look at methadone and buprenorphine for the treatment of opioid use disorder. And strong evidence shows that these medications increase retention and treatment, decrease illicit substance use, also improve functionality. And then other studies have shown a decrease in all-cause and opioid overdose mortality. So it's very important when we identify these patients to have the ability to either offer or arrange for medication for opioid use disorder. Our next slide, we talk about having a framework to screen for opioid use disorder, provide a brief intervention, and then if we don't provide the treatment, then referral to treatment. So a brief intervention after we've screened for an opioid use disorder, which we'll talk about in a few minutes. A brief intervention is to raise awareness of the consequences of substance use, motivate towards positive behavioral change, educate again about the evidence-based treatments that are available. The old way of thinking that we might, quote, detox a patient is scary to patients and is not an evidence-based approach. So helping our patients understand that we have effective treatments that are available that do not involve a detox and discharge sort of approach is critical. So how do we screen? Well, unfortunately, there are no simple, validated screening tools for widespread use. There are two tools for broad substance use screening. One is called the NIDA Quick Screen, and the other is called the TAPS, which is an acronym. So those are both two-step screening tools that have a brief initial screen and then a more comprehensive second step. We have developed a consensus method for screening for opioid use disorder in the Empower study, and we'll talk about that in one patient vignette that's coming up. Before we do that, I want to talk a little bit more about buprenorphine prescribing across the continuum of opioid exposure. So on the one extreme, we talked about opioid use disorder. These are more persistent brain changes. There's strong evidence for using buprenorphine, methadone, and long-acting naltrexone are the 3 FDA-approved medications. When we're using those in this population, and in particular, we're talking about buprenorphine now, we would think about more prolonged use. This could be years. This could be for the rest of a patient's life. We talk about using it as long as it is helpful for the patient. A DEA waiver is needed, as we talked about in this situation. Now, in this gray zone, there's limited evidence for the use of buprenorphine. If we use it, we're often thinking of a shorter-term use where we might rotate a patient to buprenorphine and then gradually taper the buprenorphine. When we're using buprenorphine in this situation, a waiver is not needed, as we've talked about. And then finally, for simple dependence, again, there's limited evidence here. Generally, we don't use buprenorphine in this situation. If we were to use it for pain, a waiver would not be needed. On our next slide, I would highly encourage prescribers of controlled substances and opioids to obtain a DEA-X waiver if you haven't. For MD and DO providers, this requires an 8-hour CME. For NPs and PAs, it requires a 24-hour CME. PCSSNOW.org has free online training for MDs, DOs, PAs, and NPs. So the link is included in that slide, and I would highly recommend obtaining that X waiver if you don't have it already to add a tool to your toolbox. With that, I will turn back over to Beth.
Terrific. Thank you, Aram. So after all of that great appropriate screening, how do we apply best methods to opioid reduction? So just to summarize some of what's been said so far, assess for opioid use disorder and for the severity of opioid use disorder, recognizing that those who screen in the mild range are appropriate for opioid tapering or for a trial using patient-centered methods. So that involves assessing a patient's interest in opioid reduction, evaluating the concerns that they have around opioid reduction and really developing a collaborative plan that will help address their concerns. Validate any fears that they have, provide education, engender trust by assuring them that you have a plan for careful monitoring and adjustment based on their response to each dose decrease. Team-based opioid reduction plans can minimize nocebo or patient fears around opioid reduction and optimize positive expectations and ultimately their engagement. Remember that 0 is not the goal. Closely monitor your patient's response, especially for mood and suicidality. Offer adjuvants to facilitate patient comfort if they're having withdrawal symptoms or other challenges. So we, in the Empower study and in the prequel study that I was discussing earlier, we support use of adjuvant medications to help patients with the process. Recognize that opioid tapering is not right for everyone, of course. And these last two, Aram and I are going to be discussing these last 2 points as we close out on the final section of this webinar. But just to give you sort of a preview, providing patients with treatment and resources, and that includes both developing virtual teams and also applying some of the resources that you have in the resource attachment PDF that accompanies this webinar. And then finally, considering rapid access to brief skills-based pain management options. So let's talk about Barry. Barry has a 5-year history of opioid use for shoulder pain. He's had a rotator cuff repair surgery. He was laid off in August, but he was a carpenter. He has a history of alcohol abuse. He endorses cannabis use, which is legal in your state. And he has a remote history of lost prescriptions and ED visits where he was requesting opioids and received opioids on some of those occasions. Barry represents a patient who has some unique challenges. Aram, I'd love to hear your thoughts on how you will approach Barry and formulate a treatment plan for him.
Yeah, excellent. Thanks, Beth. So because there doesn't exist a simple validated opioid use disorder screen, and the Empower trial developed a consensus method, which essentially took the second part of, we mentioned the TAPS. It was a 2-part screen. So we took the opioid questions from the second part and applied those 3 questions to our patients. And so, so Barry was given this screen. So we'll just go through these. In the past 3 months, did you use a prescription opioid pain reliever, with examples here, not as prescribed or that was not prescribed to you? So he answered yes to that. The next screen was, in the past 3 months, have you tried and failed to control, cut down, or stop using an opioid pain reliever? He answered no to that. And then the third question, has anyone expressed concern about your use of opiate pain relievers? He answered no to that. He had 1 out of those 3 positive, and so that triggered the next step in our Empower consensus screen, which is basically to query all of these 11 criteria, or if the patient's taking the opioids as prescribed, which Barry was, as far as we could tell. Then we're focusing on the 9 symptoms on the left-hand side. So as we queried those, we were able to determine that he did meet 2 of those criteria. So was endorsing craving and strong desire for opioid use, and then also down in the use despite consequences. He was having consequences in his relationships that were related to the opioids. And so what's important to recognize as we're querying these, many patients will identify pain as interfering with some of these domains. And again, those would not necessarily equate to a positive symptom. So we really want to focus on, is it the opioid that is interfering with work obligations or social interpersonal problems? And in Bear's case, he did have two of those criteria. So that puts him equivalent to a mild opioid use disorder. We could consider a taper using the Empower methodology. However, we may also talk to him about what the other treatments for opioid use disorder. And so moving to our next slide, we can go back to what we talked about before and use a non-stigmatizing approach. Let him know we know these are neurobiological changes that he didn't choose to have, that are happening because of exposure to the medication over time. We talked to him about buprenorphine as an option. We talked to him about tapering as an option. And we basically present those options and then ask him what he thinks would be the best treatment choice for him. And for him, he did think that using buprenorphine, using medication, would be a good option. And so that's what we proceeded with.
Terrific. Thank you, Aram. Now let's talk about Tomas. And Tomas is a retired teacher. He's been using opioids continually after his first knee replacement surgery. And you meet with him and he's very fearful of tapering, but he's willing to try. How do you approach this patient?
Yeah, great. So Tomas is really, we can kind of think of as one of our really common patients that we see, that they are on opioids, they're fearful but have some openness. And so we can think about where they are on that readiness to change scale and how much they buy into an opioid taper. And most patients that are coming in will not be absolutely ready. And so that's where all of the methods we've talked about, I like how Beth has talked about really baking the psychology into our methodology. And so if you follow the methodology and the methods that we've talked about, really you'll be already starting to extinguish some of the negative expectations and enhance some of the positive expectations, maybe starting with one of these microdose changes. So let's start to put some percentages to these. We can think of a standard collaborative opioid taper with a gradual and a flexible pace, so we might change that, but the baseline might be somewhere around 10% a month, and a range might be 5 or 20% per month. Generally, the slower tapers are better tolerated, particularly in patients who have been on opioids for a longer period of time. Now, a microdose change may be smaller than that. So often what we look at in our clinic is using literally the smallest dosage form. And if it's possible to cut that pill in half, then cut that pill in half. And I say if it's possible because if a patient is using an extended release opioid formulation, then that's generally something that you cannot cut in half. But if they're using a short-acting opioid, then we might find the smallest dosage form, cut that pill in half, and that would be our way of starting. And often that will be something more like a 2% or a 3% change. And that's really what we're often looking at as our first change. And if we can get that first change, and our goal is essentially to have our patient begin to have that lived experience that there was no major change in their pain, that they maybe have experienced some of the kind of similar pain that they have in the past. Maybe they've started to use some other strategies that we've talked about for managing pain, and maybe they're actually feeling a little bit better. But our goal is that they have they start with that lived experience that can form the foundation for positive expectations. So then we may proceed with a similar dose change. We may proceed somewhere in the 2 to 10% range every 1 to 2 months. We just think of pausing as being standard. So it's very common that our patients, whether it's they're going through a stressful time in their life, or it's maybe a holiday season, or something else is going on, providing that flexibility to pause can also enhance a patient's sense of control. Again, just bringing up that a patient may not manifest mental health comorbidities or substance use comorbidities at the start of a taper, but during or into the taper, they may begin to manifest that. So really maintaining careful vigilance throughout the taper period. Our next slide, we talk about medications for withdrawal. And really our goal is we're going so slow that our patients should certainly not have major withdrawal. Any withdrawal should be minimal and transient. However, it's important to recognize that there are medications to treat opioid withdrawal and to have some familiarity with these medications. A patient might come in and maybe experienced a rapid taper. Again, many situations you may actually increase the opioid dose to some degree to prevent those withdrawal symptoms and then start more gradually. But if for whatever reason you find it appropriate to use medications, non-opioid medications to treat withdrawal, this is a nice table to think about. So many of us know about clonidine and also know that can lower the blood pressure. Tizanidine is an analog to clonidine that can help with withdrawal symptoms but have much less reduction in blood pressure. Medications like baclofen and gabapentin may be helpful. Our patients may have tried these in the past for pain, so you may need to preempt and say, I'm not necessarily prescribing this to help with pain at this point, but I think it might help with this transition to a lower opioid dose. If patients are on high doses, we need to be cautious about adding other sedating medications like gabapentin or baclofen. So it may only be after you've initiated taper that you would feel comfortable adding in one of those medications. Hydroxyzine or diphenhydramine can be used for both insomnia and anxiety. Nonsteroidals, topicals, if those are appropriate for the patient's underlying medical condition. Trazodone for sleep disturbances, kind of our standard medications for nausea, and then something like dicyclamine for abdominal cramping, and then loperamide for diarrhea. Can all be helpful. Again, we do not expect, if we're following this gradual taper, to be having any of these major withdrawal symptoms. And I think we're on to our next case.
Yeah, terrific. So Gerald, who's been taking opioids for almost 2 decades, and he has a lot of pain comorbidities, different types of pain conditions and diagnoses. He also has depression, insomnia, he's deconditioned. The taper is being implemented due to pressures from his healthcare system. Now, he's anxious about tapering like most people, but he's sort of forced to go down this pathway, so it's implemented, and his pain increases as a result of the taper. How do you handle this, Aram?
Yeah, so a couple things on this one. So certainly if we want to go back to those principles of frequent reevaluation and flexibility. And so certainly may be appropriate to pause a taper really until we can have him kind of stabilize. He has depression, insomnia, deconditioning. Those are excellent areas that we can treat. And so again, if we widen that treatment lens, we know we have evidence-based treatments for depression, for insomnia, and help our patient begin to combat that deconditioning. Sometimes we may put ourselves in a bit of a false dilemma if we think of opioids are really the only way to treat chronic pain or the best way to treat chronic pain. And so if we have that lens, then we might think about kind of this dilemma between potentially harmful substance and effective treatment. So by widening our lens, we can kind of take us out of that false dilemma, and we can really see that we have effective treatment options, looking at something like, again, an SSRI, an SNRI for the treatment of depression. Ideally, we also have some access to behavioral treatments, which can be effective for both depression and insomnia, and then also querying about things like social isolation and other areas that we may be able to help our patient with their overall quality of life and functioning.
Terrific, thank you. So we've offered a lot of different clinical vignettes that help frame our perspective on how to approach patients individually, recognizing that the outcome of their treatment plan will really and truly be individualized. When we talk about improving patient safety and patient outcomes for opioid deprescribing, you know, the secret sauce is monitor closely and adjust the treatment plan according to the patient's response to the taper. So monitoring your patients, what does that look like? Monitor for mood, distress or decompensation, suicidality, increased pain, and also withdrawal symptoms, and applying some of these great strategies that Aram had just been describing, recognizing that if we're tapering in a truly patient-centered way, we're unlikely to have, or at least we're minimizing the likelihood of these types of occurrences, but they will happen just by the very nature of our patient population. So the only way to offer this safety net and protect our patients is to monitor closely. If you identify your patients are doing poorly on a taper, pause and protect. Pause and protect. Assess the patient from a multidimensional perspective, gather that information, connect the patient to resources, and again, strong cautions against tapering without highly structured support and relevant services in place for our high-risk patients. Sort of to summarize a lot of what we've been talking about to this point, we're talking about treating the patient and not the pill, recognizing that less is not always better. Tapering is a time of risk, and with individualized care, tapering isn't right for everyone. We can offer our patients behavioral resources, even if they're just printed online. So you have a lot of resources in your PDF attachment, and I'll be speaking about a couple of final options right at the end of the webinar. And if you have a large enough patient pool, you can even offer in-house group support, either around pain management or even around tapering. Okay, so in this last segment, we're going to talk about comprehensive care in low resource settings. And Aram is going to speak about creating virtual teams.
Yeah, so we're very fortunate in our care setting here in the VA of having interprofessional teams, and we know that interdisciplinary care is the best approach. We also know that that's not realistic in many settings. So what is a virtual team? How do you create it? Well, in kind of its simplest sense, thinking of the important members of a pain care team, and our ideal members would be someone that does some movement therapy, someone that does some behavioral therapy and rehabilitation, and then someone that has expertise in addiction. So recognizing that in certain settings, we may not have a psychologist, we may not have a physical therapist, but that if we kind of widen our focus again and look at the functions rather than a specific discipline, we know that providers from other disciplines may be able to provide those same functions. So even if we have, say, a physical trainer or someone that can, in the community, that can help our patients start moving, that's someone that we'd want to connect with, and we'd want to have a brief conversation with and talk to them about our strategies for treating pain and kind of see that we're kind of create some common approaches, and then that can now become a member of your virtual team. And the same thing with behavioral treatments. It's often very challenging to find someone in a rural community with expertise in cognitive behavioral therapy for pain. But if we can find a therapist who has other expertise and maybe not in pain, we can still help our patients with coping with pain, with treating their depression, anxiety, other comorbidities. And so that's also a provider discipline that we want to reach out to, talk to, kind of establish a common approach. If we have a physical therapist in our community, talking with them, reaching out, and rather than just putting in a referral, physical therapy, patient comes back, physical therapy didn't work, making sure we understand what our physical therapist is doing, making sure we're looking at active therapies, and not just applying, again, some of the approaches we use for post-surgical treatment, like ice and mobilizing and heat and ultrasound, these passive type of therapies, which have minimal, if any, evidence for chronic pain, making sure that physical therapist we can talk to and can start to use more active approaches with our patients. So by doing that, we can begin to knit together a virtual team and a network for our patients to offer them more support.
Terrific. Thank you, Era. When we talk about barriers to patient-centered care, it's not always about the limitations of what's available in terms of an interdisciplinary team. Sometimes we ourselves can be a barrier to patient-centered care. It is common for clinicians to have discomfort around opioid tapering conversations, any difficult conversation, but the one around opioid tapering can be especially fraught with emotion, discomfort, and this can be problematic for a variety of reasons, mainly because you may avoid even broaching the topic or enacting a care plan, or even moving forward with conversations around collaborative care or engaging the patient in their pain care plan. So the first step here is to do an assessment on yourself. Identify your discomfort in patient interactions. It's common for patient anger or emotions to lead to interpersonal dynamics that are unpleasant, confrontation, escalation in tone and voice and emotion. This can facilitate some avoidance on the part of healthcare clinicians and negative associations that healthcare clinicians can carry forward to the next visits with that patient and also to other similar patients. So it can kind of start to contaminate the clinical environment and also the therapeutic alliance with that patient and even with other patients. So the most important thing to know is that, number one, this is common, and number two, it's addressable. So very quickly, providing you with 2 diffusion techniques for patient interactions that are distressing or uncomfortable for you. So commonly this is anger or frustration, but it doesn't always have to be that. The tools that you can use, the 2 tools, is number one, label the possible emotional experience that you are observing in the patient and voice it. It seems as if you may be angry or upset, etc. You know, whatever it is you're observing, find a compassionate way to label that, name it, and bring it out into the room. Just by labeling it compassionately, this can allow a de-escalation, partly because patients are feeling observed and seen. And the second tool is to validate their experience with compassion. I understand why you might feel this way. And so in both cases, what happens with patients is they're bringing something into the room, anger or frustration. And if we're avoiding it or trying to minimize it, if we're not acknowledging it outright, the patient will naturally escalate their emotion and their tone because they're not being seen. They don't feel that their experience is being appreciated. So these two techniques, name it and validate it, allow you to quickly communicate to them that they are being seen, heard, and validated. And that can allow for a platform of de-escalation. The last thing I want to say on this is that if you feel that you can benefit from ongoing coaching in this area, Dr. Claire Ashton James is a professional who specifically works with healthcare clinicians to improve patient-clinician interactions, healthcare clinician satisfaction, and specifically around opioid tapering, these difficult, highly emotional conversations. Information about her exists in your PDF resource guide that accompanies this webinar. So Aram, I will turn it over to you for protecting the healthcare team.
Great. Yeah, and those are such great tips. Beth, I'll say we literally use those on a daily basis. So those are really excellent. So in this environment of kind of broad recommendations for opioid prescribing, we can think about how do we make sure we protect the healthcare team. So on our next slide, we can look at kind of a series of check boxes that we can make sure that we're doing. First one is make sure that we have face-to-face visits on a regular period and that we document well. We certainly should be documenting well on all of our visits, but if there are cases we want to document a little more thoroughly, these would be those cases. So how frequent? CDC recommends every 3 months at least, or more frequent as depending on risk, for long-term opioid therapy, and then also importantly recommends 4 dose changes follow-up in 1 to 4 weeks. So for those dose changes, again, up or down, much more frequent follow-up. Next one are treatment agreements, informed consent. Contracts are an older language that has more of a legalistic approach, and really these aren't legal documents. The purpose of a treatment agreement and informed consent is really providing education and providing a platform to make sure that you're on the same page when you're working with your patient. Informed consent is required in the VA, and that's because long-term opioid therapy has been determined to rise to the level of risk requiring an informed consent. So we complete informed consent on all of our patients who are on long-term opioid therapy. So one of those, but certainly a written treatment agreement and at least a verbal consent, informed consent is critical. In some settings may use a written informed consent as well. Use of the prescription drug monitoring program is also critical. So CDC recommends use of the PDMP before prescribing, at least every 3 months, and then increased frequency based on risk. Make sure to check your local state guidelines because some states may actually have laws about checking the PDMP. Some may be more stringent, and certainly you'd want to follow state law and you'd want to follow the more stringent of the recommendations. Urine drug testing, both randomly and periodic, is recommended. there's no clear evidence of the frequency of urine drug testing, and that's why many recommendations talk about at least annually, but certainly that should be increased based on risk, and importantly, random urine drug screening is part of that recommendation. And then finally, overdose education and naloxone prescription is another key part. And CDC recommends that for patients that are at higher risk, so greater than 50 morphine equivalent dose, prior opioid overdose, benzodiazepine. But there are also other recommendations to use this more broadly. And one study in San Francisco looked at really co-prescribing naloxone with all patients on long-term opioid therapy and did find a lower rate of emergency department visits. So these are the key parts that we need to make sure that we're doing and documenting. On our next slide, we included just some screenshots from a CDC checklist that is excellent. This is also included in the resources with the webinar. Okay, and then our next slide, and this rounds out the part on protecting our practice and healthcare providers, is discharging patients from practice. So first of all, I want to make sure we're distinguishing stopping or changing a treatment from termination from practice. The former being more common, and really the latter, termination from practice, much less common, and we want to try to avoid if possible. In general, when we're stopping or changing or deprescribing opioids, we want to, as we've talked about, we want to make every effort to engage our patients in care, ideally even often with more intensive support. And again, as we've talked about, if opioids are continued, maintain that close follow-up for several months after discontinuation. And then we've talked about screening and assessing for opioid use disorder. Sometimes we might see unpleasant behaviors that are driven by an underlying untreated mental health condition or opioid use disorder. So keeping that in mind is critical. And then finally, there are exceptions. So exceptions would include significant disruptive or threatening, otherwise dangerous behavior that would compromise the safety of the healthcare team. Certainly would be an instance where we'd look at discharging a patient. In general, again, follow your state guidelines, but in general, we need to give patients notice. Often that's a 30-day notice. Often it's written notice. And an exception to that 30-day may be, again, a dangerous situation where the healthcare team is in danger. But those are rare, and in general, we really want to look at avoiding discharging patients. We want to keep our patients, engaged in care as much as possible. And I think I'll turn it back over to Beth.
Thank you, Aram. So in this last segment, before we go to Q&A, I want to talk briefly about behavioral pain medicine in low resource settings. So included in your attachment resource PDF, there are various informations about when to refer to a psychologist or a pain psychology specialist, and also what to do when you don't necessarily have someone in your community available. And this is important for a couple of reasons. Number one, we've talked at some length about the biopsychosocial model of pain, how pain is experienced and how pain is best treated. We don't always willfully treat pain biomedically. A lot of times what people will say is, well, I wish I had someone to refer to, but I don't. I don't have a psychologist in my community. My patient doesn't have access to these resources. There are a lot of different barriers to behavioral medicine, or what we call pain psychology. And you're well familiar with these. They include insurance coverage, the time that it takes to attend multiple sessions, copays, Rural settings, resources are notably poor, and most psychologists do not receive specialty pain training in undergraduate, graduate, and sometimes even postdoctoral training. So there are, the majority of psychologists in the community are lacking this skill set to really address pain from a behavioral perspective. So to address this persistent need, I and colleagues developed a solution that offers efficient, rapid access to skills-based, evidence-based pain medicine for individuals living with chronic pain. And this is a single session pain class. The name of it early on was From Catastrophizing to Recovery, but we've since renamed the treatment Empowered Relief. And the concept is that every person should have access to a basic level of behavioral pain medicine so that they become equipped to best control their own experience of pain, to apply self-regulatory skills within the context of pain, which is in and of itself is very distressing, but then layering onto that opioid reduction and the distress and stress that is caused from that. So this is 2 hours. It's a one-time class where patients can come, they can bring their family members. We offer this treatment for free at Stanford. And again, patients learning these skills so that they can learn how to self-regulate, but essentially dampen pain processing in the nervous system by learning how to calm their nervous system. Research on this class has been published, and we are just finishing now a 3-arm randomized controlled trial. This is funded by NIH. We're seeing highly promising results for this research. We'll have those final results published in the first half of 2020. Meanwhile, we are offering certification workshops for healthcare clinicians so that they can become trained to deliver this single session class and embed it into healthcare systems. It is in a whole host of healthcare organizations in the United States, in Canada, in Denmark, in the UK, and also Australia. So if you or your colleagues are interested in providing your patients with this basic level of behavioral pain medicine, there's information included in your resource PDF, and you can also visit the Empowered Relief website and learn more. The treatment itself is free. We give you all of the information, all of the resources, everything you need to deliver the treatment is free of charge. There is a cost for the 2-day certification workshop to cover the human resources and the time delivering the trainings and to assure fidelity and standardization in the treatment. So that's the final piece that I wanted to share. I know that there are a lot of psychologists and behavioral medicine specialists attending the webinar, and even for the non-behavioralists, we train physicians, physical therapists, social workers, all healthcare clinicians are welcome to become certified instructors. I want to close out by, again, drawing your attention to the PDF attachment resource that accompanies this webinar. You will find there are tip sheets, online resources, low cost and free resources for your patients and even for clinicians. We include the HHS tapering guidance that Aram referred to multiple times, the CDC prescribing checklist, VA taper tool that also discusses adjuvant medications for withdrawal, OUD, the opioid use disorder provider guide, the professional coaching resource, and also information on Empowered Relief. So all of that is right there at your fingertips so that you can engage with those as you see fit. And now with that, that is the end of our formal presentation, but we do have some questions now. So I see that there's one here on medical marijuana. So I'm going to pose that to you, Aram, first. The question is, what about medical marijuana, and how do you feel about that for your patients?
Yeah, it's a great question, and it's a common question. Very frequently comes up, as you know. So, and again, we could spend another 2 hours, if not a full day, on medical marijuana. So I'm going to be very brief on that. Essentially, I think a couple of factors we need to recognize is that currently there's, for much of the state-sanctioned medical marijuana, there's not regulation. So, there's many different constituents in the marijuana plant. The most common ones that people talk about are THC, the psychoactive substance, and CBD or cannabidiol. And you may even see products that, kind of purport to having only CBD or a certain amount of THC. But it's important to recognize that when that has been studied, there's a very high degree of those products either not having what they say they have in them, or having something that they don't say that they contain. So, for example, CBD product might have THC in it. So a patient may think that they're getting something that's non-psychoactive, but may actually have a psychoactive component. So we certainly need more regulation and products that are regulated. We definitely need more information about, for example, how these different constituents work. There are some studies that suggest some benefit for pain. What I really am looking for are long-term and functional outcomes. So some of the studies with opioids and even some of the meta-analyses that were published, averaged outcomes were in the number counted by weeks, so 5 weeks, 6 weeks, whereas we're really interested in much longer outcomes. And we know that our patients often do come in saying that they feel better, whether, and that can be with an opioid or with marijuana, but we certainly need more information about what are the long-term outcomes, what are other interactions with other medications. So those are some initial thoughts. And I remember seeing, as you were presenting on the Prequel study, a certain percentage of patients were on marijuana. Was there any data on kind of at the 16 weeks, what kind of percentage of patients taking marijuana?
Oh yeah, thank you for asking me that question, Aram. So, I mentioned when I was reviewing our pilot data for the Colorado study, and we found a high rate of marijuana use at baseline, 37% of patients who entered the study. And I thought that because it was an opioid tapering study, that we would be likely to see increased use of marijuana as patients decreased opioids, and was frankly stunned that was not the case, that, we have a small N because, this was overall a relative, we're talking about 51 patients and then, 18 using opioids at baseline, or sorry, using marijuana at baseline. And so the numbers are pretty small, so I'm not going to get into percentages, but what we found overall was that several people either decreased marijuana use or stopped marijuana use over the course of the opioid tapering study, and nobody who did not report baseline marijuana use reported de novo use of marijuana as a consequence of taping. So the big takeaway is that my hypotheses were not met, was that marijuana use actually decreased for everyone, for on average for people using marijuana. Now, we didn't ask about dose and we didn't ask about frequency. So these are limitations. We're diving into that in detail now in the Empower study. As you know, we're assessing marijuana use very carefully because we really need better data on the relationship between marijuana and opioid use and how reducing one might influence the other. So thank you for asking that question. And then I'm gonna ask you another one, Aram. Why is tapering a bad option in patients who have opioid use disorder?
Yeah, that's a great question. So we talked about that it was a bad option. So why is that? Well, we actually have data on that. So a trial called the Prescription Opioid Addiction Treatment Study, led by Roger Weiss, looked at patients who had an opioid use disorder to prescription opioids. And one of the hypotheses to that study was that a prescription opioid use disorder would be somehow less severe or different than an opioid use disorder to heroin or an illicit substance. And so what they studied was looking at basically a rapid taper or a detox versus using buprenorphine. And the taper period was 4 weeks or 8 weeks in patients with a prescription opioid use disorder. And what they found is in both of those time frames, the taper detox only without buprenorphine, there was a almost universal return to opioid use. So it was more than 90% of those patients returned to opioid use. And so that's one of the main factors and concerns, is that if a patient has an opioid use disorder, those persistent brain changes are there that are creating things like craving, use despite consequences, everything that we talked about, even in the absence of an opioid. So even once the opioid has been stopped, the brain changes are still there. The person is still experiencing craving. They're still experiencing a strong drive to obtain opioids. And now, as you pointed out in the CDC slide, in this current wave of the opioid epidemic, many of the deaths are coming from illicitly manufactured fentanyl. And so, something else insidious is that some of the cartels have do things like steal pill presses, and so they'll basically press out pills that look exactly like a pharmaceutical pill, only they have fentanyl in them.
Wow.
And so it's just extremely dangerous. And so our patients that might be saying that the most common source of non-prescribed opioids is friends or family, but we don't know where those pills came from often. So if those pills were coming from an illicit source, they have fentanyl in them, one dose could really be lethal. So going back to your question, if we're tapering a patient who has a 90% or more likelihood of ending up back on an opioid, and if that opioid were to be an illicitly obtained opioid, that can be a potentially lethal consequence.
Wow, so important. Such great information. Thank you, Aram. And I have one more for you. This is from a clinician. How do I document clinical visits to protect myself from the DEA, state licensing board, from accusations of overprescribing? So either the DEA or the state licensing board, from accusations of overprescribing. Such a common question.
Yeah, and unfortunately there is a lot of fear, as we hear, on the part of providers, prescribers about that. So kind of going back to that checklist that we showed, and then the CDC prescribing checklist in the resource guide is an excellent source to use. And if we're making sure we're doing all of those basics, we're seeing our patients regularly. And when you see your patients, and in that CDC prescribing guide, there's a cue to be documenting risk-benefit assessments. So we talked about that as one of our starting points. So doing the risk-benefit assessment, documenting that in the chart, and we say phrases something like, the risks and benefits of tapering was compared to the risk and benefits of continuing on the current dose, and whichever one we decide, say we decide tapering in that case, the risks and benefits of tapering or the risk-benefit profile was determined to be more favorable than alternative treatment options. Having that documented is really important. And so again, doing that assessment, documenting maybe a little more carefully than we do on other patients, and then following all of the other parts of urine drug screening, prescription drug monitoring program, naloxone, prescription and overdose education. Those are the key factors to protecting our team, and then also making sure that we have a written agreement on file.
I love how your last response, which is really focusing on, protecting the clinician and the healthcare team from these accusations, DEA and state licensing, but it's really about how do we protect ourselves. That really dovetails so nicely with this parallel process of how do we protect our patients. And in both cases, it's monitoring and documentation. It's really, that due diligence, and that carrying that philosophy forward into protecting the team, and also throughout patient care ensures it ensures the well-being of all of the stakeholders. So thank you, Aram.
Absolutely.
One question here, this one for me, Beth, could you talk more about enhancing positive mindset and reducing negative mindset in patients with chronic pain who are taking opioids? It's a great question. We've been talking about this throughout the past 3 hours. How do we best engage patients? But very specifically, this piece on the psychology of pain and the psychology of opioid reduction, recognizing that virtually everyone has at least some trepidation. But it's a continuum where some people might have some trepidation and others are absolutely terrified. So what do we do with that? And I wanted to just remind everyone that in your resource PDF, the very last document is a published article on optimizing placebo and minimizing nocebo for opioid reduction, and some of this fear around the process. So that's one of the key takeaways, is that you do have at your fingertips a referenceable clinical toolkit for how to initiate these conversations, how to be with patients through, with their emotional experience, and how to address that fear in a way that is beneficial, so that even when patients are maybe coming at you with anger or frustration, you've acquired a couple of skills and tools for how to manage them in that process, and then be more effective with patients as you help move them forward along the continuum of readiness, their willingness to work with you, their willingness to trust. We did include some tips and scripts for initiating these conversations, as well as that the toolkit for how to address the various aspects of fear that patients will bring to the table. So, expect it. You've probably already been receiving it. You're already managing it to some extent or another. What we endeavor to bring forward in this webinar are some tools to be more effective in these patient interactions that you're already engaging with. Because if you're more effective, not only are your patients getting better care, but you'll have a higher degree of satisfaction yourself in working with this patient population who very clearly has additional challenges. And, as evidenced by all of the content that we've brought forward over the past 3 hours. So I think we may have time for one more question if you're up for it, Aram.
Great. And before that, I'll just say that that article on placebo and nocebo, excellent, has a nice table in it, also with some nice phrases, and I know also included there's some sheets with nice phrasing and tips that can be really helpful.
Oh, awesome! Thank you, thank you. Okay, so here it is. You talked in your portions, Aram, you talked about urine drug screens. And this question relates to the costs for that. So that's part of maybe the process for assuring good patient care, and that we're steering our patients down the appropriate care pathways. And so urine drug screens are a tool, but there's costs associated with them, and sometimes those can get passed on to patients who might not be able to afford them. And this is a unique challenge. So what can you tell us about that?
Yeah, that can be a challenging situation. Our personal experience is different here in the VA, but in the private sector, I'm aware and have heard about situations where it does seem like practices are using high-cost urine drug screening approaches that seem to be more kind of financially driven rather than kind of patient-centered approaches. So, more standard approaches are often low-cost screens initially, and then reserving some of the higher-cost testing for confirmations when that initial testing is non-concordant. So again, I think I like how you were just phrasing that question, and really I think we need to continue to think about what's the most patient-centered approach. And urine drug screening, just in general, can be seen as sometimes as punitive, sometimes as, again, as this question brought up, associated with high costs. So I think we always want to come back to what's the purpose of it. Again, the purpose is trying to recognize a potentially dangerous situation like an unrecognized substance use disorder, an unrecognized opioid use disorder, more rarely, but still we need to keep our eye open for diversion. So we know that we really want to use urine drug screening as a standard approach for safety and ideally to actually enhance our communication with our patients. So kind of framing it that way with our patients generally will kind of set us on that collaborative partnership type approach.
Mm-hmm. Yeah, I love that. Great, thank you. Well, I think we are right at the top of our time. So I want to thank you, Aram, for being with me and doing this webinar together. And I want to thank everyone who has been in the audience and has been learning throughout the 3-hour webinar. Please visit the resource PDF that accompanies the webinar. And we want to thank you for your time and attention.
Excellent. Thank you, Beth.